Welcome back. Today we are focusing on acute asthma exacerbation in adults, how to recognize severity early and manage it safely in the field. When an adult is having an asthma attack, it's tempting to think of it as just wheezing. But severe asthma is not mainly an oxygen problem. It's an airflow problem. The airway narrows in three ways at the same time. The smooth muscle tightens, the lining swells, and thick mucus building up. Air can get in, but it struggles to get out, especially on exhalation. That leads to air trapping, hyperinflation, and rapidly rising work of breathing. And that's why the sound can mislead you. A loud wheeze can mean tight airways, but a suddenly quiet chest can mean something else. Air is barely moving. So early on, I'm not asking how loud is the wheeze. I'm asking how close this patient to fatigue and failure. At the same time, I give oxygen if it's needed, and I titrate it to a clear target. I want the saturation above 94%. But I don't let the oximeter distract me. In asthma, the patient can be deteriorating even before saturation drops, because the real danger is ventilation failure and exhaustion. Now I need to decide which path I'm on. If the patient is uncomfortable but still stable, they usually breathe in under 30 a minute, they can speak reasonably, and the room air saturation is typically above 92%, that's a mild to moderate attack. Now, if they're dyspneic at rest, breathing over 30, struggling to speak, and their saturation on room air is below 92%, that's severe. And severe means I don't wait and see, I treat. Then reassess fast. And then there's the critical patient, the one who looks tired, quieter, less responsive, sometimes even too calm. If chest movement is poor, or the chest becomes silent, that's a warning. Not because they improved, but because the air may no longer be moving. So, how I treat this in a way that matches the physiology? I start by opening the airways quickly. If the attack is mild to moderate, I begin with nebulized Ventolin, 2.5 milligrams. If it's severe, I go straight to 5 milligrams. Then I reassess. Not just the sound, the work. Is the breathing less frantic? Can they speak more? Is air entry improving? If the patient still looks tight, I repeat treatment, typically every 20 minutes, up to 3 doses early on, while I keep tracking the trajectory. In moderate to severe attacks, Ventolin alone is not the whole plan. That's when I add Atrovent, ipratropium, 0.5 milligrams by nebulization. In severe cases, I can repeat it up to 3 doses early on, usually paired with the Ventolin treatments. Now, bronchodilatators help quickly, but they don't fix the underlying inflammatory surge. That's why steroids matter, even though they are not an instant relief. So early in the course, I give solomedrol. It's methylprednisolone, 125 milligrams as a single dose. I don't expect steroids to turn the patient around in 2 minutes. I expect them to change what the next hour looks like and reduce the risk of relapse. So the inhaled meds are the foundation, but in truly severe case, I don't rely on nebulizers alone. Now, if there are signs that the patient is heading toward a respiratory failure, I don't wait. I give epinephrine early. For a severe attack, I give 0.3 milligrams subcutaneously once. If this is a life-threatening or the patient is failing, I give 0.5 milligrams intramuscularly once. And we should be cautious with older patients, especially over 40 or anyone with ischemic heart disease. If the patient is still in significant distress, despite aggressive bronchodilation, I think about magnesium. The dose is 2 grams IV, diluted in 100 milliliters of saline, infused over 10 minutes. But if the systolic blood pressure is below 90, we should avoid magnesium, because hypotension changes the risk profile. There's also a practical point for the most advanced airway scenario. If the patient is intubated and still severely bronchospastic, and inhaled therapy is not reaching the distal airways effectively, there's an option to deliver Ventolin directly through the tube, 5 milligrams, diluted in 5 milliliters of saline into the endotracheal tube. This isn't a routine step. It's a we are already deep in the critical pathway step, and it should happen alongside rapid transport and continuous reassessment. Through all of this, I keep reassessing in a disciplined way. Every 5 to 10 minutes, I'm asking the same questions. Is the work of breathing improving? Is speech improving? Is mental status stable? And is air entry getting better or getting quieter in a dangerous way? During urgent evacuation, I can run normal saline at about 20 milliliters per minute, up to roughly 500 milliliters, mainly because of the severe tachypnea, poor intake, and stress that can leave these patients relatively volume depleted. And maintaining perfusion supports the overall resuscitation while treatment continues. Now, before we jump to airway management, there's one step that can sometimes bridge the gap: CPAP. If the patient is cooperative and there are no contraindications, CPAP can reduce work of breathing and improve ventilation while medications take effect. But CPAP is not a substitute for recognizing failure. If the patient is tiring, becoming altered, losing chest movement, or cannot tolerate the mask, that's not a CPAP patient anymore. That's a patient you need to prepare to ventilate and manage an airway for. The key is trajectory. If the patient is improving, speaking more, moving more air, and working less, keep treating and transporting. But if the patient is worsening, is quieter, more exhausted, less responsive, escalate early and don't get stuck on scene. Finally, we need to understand that we're not treating asthma in a vacuum. We always look for the trigger because this changes the risk and it changes our expectations. Infection, allergen exposure, smoke, exertion, and missed controller medications are common. And if something doesn't fit, I keep differentials in mind, like anaphylaxis, pneumonia, pneumothorax, or even pulmonary edema. History matters too. If the patient has required ICU care or intubation for asthma before, I treat them as high risk. The same goes for repeated hospitalizations or frequent emergency visits. It often means poor baseline control and limited reserve. Those details don't change the medications. They change the urgency. They lower my threshold to escalate, to pre-alert the receiving team, and to anticipate deterioration, even if the patient looks okay for the moment. Managing acute asthma well is about recognizing the dangerous trajectory early, understanding that the enemy is airflow failure and fatigue, and escalating treatment decisively with a constant reassessment. Because in asthma, the patient who gets quieter is not always getting better. Sometimes they are running out of air movement, and that's exactly the moment where the right sequence matters the most. Thanks for listening.